You are listening to the Umbrella Hour with Dr. On. Welcome back. In this hour, I will be speaking with Dr. Raoul Sanchez. Welcome to the Umbrella Hour, Dr. Sanchez.
Welcome. Thank you for having me.
I'm curious how you got started treating trans kids. How did that all come about?
So I'm just going to go back a few years. First of all, I'm a pediatrician. I practice in Jacksonville, Florida. Several years ago, I was approached by Dr. Jeff Goldhagen, who works with Partnership for Child Health through UF as well. And he wanted to initiate a collaboration in Jacksonville to help advance the care of the LGBTQ population, pediatric population in particular, with an emphasis on trans care. And I didn't feel I knew much about it, but I agreed that we were sort of slightly bit of a desert in pediatric care for the trans community in Northeast Florida. And so I said, well, yeah, sure, I would love to do that, but give me some time to learn. First time independently, I wanted to go to several of the trainings that are offered both through the Fenway Institute in Boston, that's just Harvard's LGBT healthcare education initiative. I also spent some time learning about some of the other protocols that people offer for not only learning about LGBT care, but about trans care through UCSF. And really wanted to learn what the Endocrine Society, because all of this really sort of comes out of practice parameters published by the Endocrine Society back in 2017. So doing that, doing conferences, doing my own independent webinar studies through them, I did some intense work over about 6 to 9 months. And during that time, I also let the word out that, hey, I'm really trying to become a LGBT affirmative pediatrician. I made sure patients were starting to be aware of that. And so I did start to actually see some trans individuals. And I think I'm going to just stop there for a second. And really the current terminology that is acceptable and is all encompassing for the community is transgender and gender diverse. So often we say TGD, transgender and gender diverse pediatric populations. So I think I want you to know that when I say trans, I'm being respectful of the entire population. And that includes non-binary and many of the other identities that people have. But it's just easier to say trans. So during that time, I spent a lot of time, and I had some goals in mind. Like I actually at the very beginning sat down and said, if I'm really going to do this, I need to do it properly. I need to do it correctly, and with clinical expertise, understanding the research and everything. And so my goal was to really do that. I needed to learn it well enough where I can teach it. So that was number one. Number two, I wanted to be able to properly and adequately take care of my patients with all current practice recommendations, parameters, and I really wanted to understand what other people were doing in other centers. I also wanted to find a way to advocate. And in doing all of that, I also had to kind of help to understand the community a little bit, what resources, what allies are here, because the proper approach to the care of the trans community is through collaboration. And so I just individually met with each of my mental health providers that I still work with that are amazing and sort of discussed their involvement. I wanted to understand what their training was, what their comfort level. And so I just kind of developed these allies. It was really fantastic. And this has been able to expand to now other physicians and in different fields, and even ancillary fields such as voice and communication or speech therapy, we can say. Along those lines, I'm also in a group practice, right? So I wanted to really allow my partners to understand what I was doing. So it was sort of presenting things to my partners and transforming my own practice, because part of this too is if I realized if I was going to really become the affirmative caregiver that I really wanted to be, I needed my practice to also be affirmative. I needed the nurse I worked with, my schedulers, my front desk people. Fortunately, I have the skill set where actually I'm the in charge of my electronic medical record, the physician in charge of my medical or electronic medical records in my office. So I had the expertise to know how to transform that. It really takes some nuance to understand that. So So this was like, it just touched a lot of areas, right? And all roads kind of led back to the Endocrine Society and to WPATH, so the World Professional Association for Transgender Health. So I did go through the WPATH training. They offer both beginning and advanced training, which I've done all of that. I also did the beginner's training twice because I just like to stay up on things. So every year I try to do something with WPATH. And then I also did a WPATH mentorship program, which is a 10-week where you meet with other healthcare providers, not only in the United States, but actually throughout the world. And we have somebody who is the head of that group. And, we just learn from each other through cases that we present and everything. So it was not sort of like I just cracked one little book and I really, really tried hard. I wanted to do this right. And this has really opened up amazing opportunities, connections with people. I've been able to meet some incredible families and patients that have endured so much. And with each person you meet, and that's the whole thing, with each patient I met, it kind of drove me to work harder at doing this and to do the right thing. So I've been able to be on the radio, to do some local advocacy. And I've also been able to teach now. I taught a couple of classes in LGBT affirmative healthcare at UCF's College of Medicine. And now I'm doing this at JU, at Jacksonville University. So it's kind of exciting. It's been, like I said, it's been a neat journey. So yes, Florida has been a rough place to in North Florida to do all this. And as you know, throughout the last few years, there's been some rulings, there's been some laws that have been passed, and there's just still some things to come that have created further barriers for this population that already faces a lot of barriers. So that's been a challenge for sure.
It is my understanding that youth who are currently receiving hormone treatments are able to continue. That was my understanding. For the ones who are new now, who are seeking HRT or blockers, they must enroll in a clinical study conducted through universities in Florida. When I went to look up the information to see which universities were participating in clinical studies, I couldn't find anything. There was nothing that led me to believe that that's even something that's possible at this point in time. What is your understanding?
I'm going to bring clarity to that. So I think what I'm going to do is maybe I'm just going to jump back a couple of years and lead into where that is right now, because I think it's important to understand the backdrop. And really the backdrop affects a broader audience. I would say the entire LGBT pediatric population. It's not just the trans youth. So if you go back to around July of 2021, that's when July 21st actually of 2021, that's when the Parents' Bill of Rights was passed. And it seems harmless and it seems okay because it kind of gives parents the appropriate right of education, of how education is run with their child. However, because of that, it also opened it up to, if a child, it goes to a school counselor, for example, and reveals something about their identity that might be either a sexual or gender minority, or reveals it to the teacher, it becomes that teacher and that counselor's legal responsibility to inform the parent, which, many parents would say that they want to know, but the truth is we need to realize that there's a large population where this might not be appropriate or acceptable. I've had patients that really have, experienced not only bullying in their schools, but bullying at home. They're aware of those things. We need to put the trust in the child to know when it's appropriate for them to be able to come out and share these things. And I think that violates that a little bit. So that started all of this issue. And then it moved on to the passing of the Parents' Rights in Education Law, or what's famously known as the HB or House Bill 1557, or the Don't Say Gay. We've heard of all that. That kind of took that even to a greater extent and has sort of, required for many schools, the removal of any like pro LGBT clubs and, some of these things that these kids really need for support. The problem there's a greater, so it not only has the pediatric population struggled with feeling, I would say, ostracized, stigmatized, lack of support from their school officials, from our government, right? Like our government is telling them it's not okay to be who you are. It's telling even like our kids who have same-sex parents that it's not okay to share that at school, right? So there's problems with that. But what we've seen from research from the past, like, and you can go back pretty far during the time of Prop 8 when California was working with that with Proposition 8 in terms of gay marriage. What the period of time prior to the passing of that, we saw, and it was like proven in research that they saw an increase in bullying of kids from other kids, because kids are aware of what's going on and they hear these things from their parents, they see these things on the news, and these kids that were gender or sexual minorities, or even those that were questioning youth, actually had an uptick in bullying during that time. And so, and I don't know if somebody is actually studying this right now in the state of Florida. I'm not sure. I wouldn't be surprised if we see the same thing. I can absolutely say that so many of my patients have experienced so much bullying at school that many of them have been homeschooled. So many of my trans patients, and it's because of that, and it's because when the government is saying it's okay, then it just all of a sudden becomes okay, right, for everybody else. So that's a problem. But then we can move on to, I would say, I think it was April of 2021, where there was a press release that was done it was in honor of National Adolescent Health Month. The U.S. Department of Health and Human Services kind of releases these press releases. Anyway, in support of that, they released a press release that talked about some different things. It was like a two-page release. It can be looked up online. And it talked about different things like mental health, COVID health, and then among those it was gender affirming health and what that means in the pediatric population. And so very, very appropriate, very research based and supported by the medical community, medical and mental health communities. And then in response to that, our Surgeon General released something in response to that denounced social gender transition, denounced puberty blockers, denounced any gender affirming homotherapy, all these things. And really in that press release that he did in response to that, it was inaccurate the way the research was quoted and the way the research, without getting into too much detail. But see, all these things have just kind of created this anti-gay, but in really, or anti-LGBT, but in really anti-trans backdrop. So that led to then Medicaid in August, I think it was August of 2022. I think I actually said the press release was in 2021, by the way. It was in 2022. I apologize. I'm getting my years messed up. In August of 2022, then Medicaid formally banned any care for the and Medicaid is not just for under age 18, right? There's people over age 18. Any care for trans individuals. That's hormones, that's surgical, that's everything. And then that led to what's unprecedented, which is this ruling. This is, so none of the states in our country have done this, so we're like the sort of the lead on this, and it's not really a law that is like all these other things are laws, right? This is more a ruling within the medical community that affects the way that medical doctors, MDs, and doctors of osteopathy, DOs, can practice. So what the ruling basically does is, and right now it's not in yet. It will probably go into effect around March, based on the timing with the voting and the period where you can make open comments and all this kind of stuff. But what the ruling will do is it will ban any patients that present that are under the age of 18 that need care. So any trans individuals that need care, even despite the fact that they might have gone through all the appropriate workup, I mean, for lack of a better term, but workup and time spent understanding and being prepared for this. And despite the consent of their families, the assent of the child, those patients will not be allowed to initiate any care by MDs or DOs in the state of Florida. Individuals that have already started care, they will be grandfathered in, and they will be able to continue their care, but there will be no individuals. Now, as to what you're referring to with the research, so you can think of the medical board as MDs and DOs in a way in terms of medicine practice. So far, what it appears is that the MD side will not allow, even for individuals that are entered into an IRB research project, which are usually pretty strict entry requirements. And often we're talking about, there might be one in the state of Florida. Like, in other words, like, where is somebody in South Florida to go find an IRB research? I mean, it creates a tremendous barrier to care. Okay. But any MD will not be able to still be a part of leading that, entering a patient into that. I am an MD, if I had an IRB research project, I would not be allowed to. Okay. And currently, from what we understand, the branch of medicine that's the osteopathic part will allow that. Now, there is not currently, although they're working on it, an IRB research project led by a doctor of osteopathy in the state of Florida. Last I knew, at least within about a month ago. But we still don't know if that is going to be the case. It is possible that because from what I understand, there were several people replaced or voted on to or assigned to the Board of Osteopathy by Governor DeSantis in late December. And I don't know if that was done to sort of change that vote or not. This is where I'm just supposing, I don't know. So, but we're going to know pretty soon if the osteopathic board will also have that same part of that ruling, which will not allow an IRB. So we don't know that yet.
We will take a commercial break.
UK Health Radio, the station that makes you feel good. UK Health Radio, the station that makes you feel good.
We're back from our commercial break. Is there a sense of vulnerability with the changes that have come about? How has that affected your practice and relationships within your practice with other pediatricians?
Well, that's a fantastic question. And, that was always a concern early on for me. And I have to just tell you that my partners are incredible. They're so supportive. They want to do because I provide all of the gender care for my patients, but they show up sick sometimes, and I might not be at work, or I might not be able to see them. And my partners have just embraced this population so lovingly, and they really try hard to do all the proper pronouncing, naming, all those things. They're infuriated, like I am, about everything going on, about the attacks on the LGBT community. We talk about it regularly. I even have another partner that I'm now mentoring, and she is also starting to provide gender-affirming care for the population. She went through training, but I'm mentoring every step of the way with her. So my practice has really become. It's just really become an appropriate group to manage this population, I've always loved them, and now I even love them more because they're doing the right thing.
Because you teach students, what are some of the stumbling blocks that you continuously see when you are dealing with students who will be possibly working with this population?
I have now, so over the last, I did go to UCF's medical school over a couple of years, and this last year, because of the pandemic, I think it was because it was just too soon that I could not, they wanted me over there and I just couldn't do it. And so like the last couple of years, I've sort of transitioned more into staying in Jacksonville. So JU has incorporated me as part of a class I teach to their nurse practitioner students. And in the fall and in the spring, I'm going to teach the class twice, and each semester we're going to continue to add more topics. Like right now, the topic is LGBT affirmative healthcare, and over the summer we're gonna add a mental health component to it, and in other words, it's going to continue growing there, and all their students are going to go through it, and they're very embracing. So it's not a thing where it's a pick or choose. It's just going to be part of the curriculum. I can't say that I maybe understand on the student perspective because they're required to take the class, like in terms of what barriers they might have or whatever. But I can say that as part of my course, I make sure I talk a little bit about bias, because I think it's very, very critical to understand the implicit and the explicit bias that we all have regardless, even that just we don't even realize it, and it really drives the way that we see others. It drives the way that we practice. It drives the way that we think. And so, but as healthcare providers, we need to not only face that, realize that their bias is present, realize when it happens as we speak, as we do things, as we think, as we process, as we see patients, and then just learn how to lessen that bias and how to like check it in at the door, right? When we're seeing our patients. So to me, maybe that's my own concern that I'm creating in my mind, but I think it's a real concern. And I had to personally, when I started all of this, I didn't understand, to be honest with you, 5 or 6 years ago, I really didn't understand the concepts of gender and sexual orientation. I just didn't, and it's okay. I didn't, because I hadn't spent any time with it. So I had to overcome my own biases as I was learning about it. Right. But it's all about having an open mind. It's about two things for a medical person. Number one, does the research support a certain way, viewpoint? Do all the major medical societies support this, which they all do. When I say this, I mean gender affirming care. And then what is the lived experience of your patients? Okay. Like, in other words, does this kind of go along with what the research is saying? And I should say one more thing, which is also, there's a lot to say about consensus experience with the experts. So in other words, not every little bit of let's say trans medicine has been completely researched out. I mean, because this is a fairly new field, right? So you also have to rely on the experience of experts in gender centers and so forth, as those things are continuing to be worked out. And it's like this in so many other areas of medicine, like the use of antidepressants and for postpartum depression. There's so many things in medicine that we do that hasn't been researched to death, right? It just takes time, but that's where you rely on that experience. So I don't know, I kind of got off topic, I think, from what you were saying, but I guess just to say that all of those things I think are important. And then I would say that bias is my biggest concern as I teach. I just really want people to understand that they really have to approach this from the way that I have said, by research, by consensus opinion, and by personal patient experience.
There are so many types of bias: group, social, community, and you address it up front. And that's perfect, because I think anytime anyone is learning something about trans care, these lessons can bring up uncomfortable feelings for some people, particularly when it revolves around surgical procedures. You have a tremendous amount of empathy for your patients, and I imagine that comes across to the parents and families as well.
So remember how I gave you my background and all the work I was doing? There was a point where I had to sit down and create, say, consent forms for hormone management. And I say that back then because now the general consensus is not really to make people sign consent, because you can just verbally consent, right? In other words, signing consent forms also creates barriers. It also kind of says, hey, we don't make you sign consent forms for anything else, any other treatment. Why are we making you do it for this? It just creates more stigma for the population. The only reason why I have kept a little bit of a model of signing papers is because I like to actually give people stuff to go back as we discuss how we're going to treat. I never, I was kind of, hey, read this, go back. We're going to come back and discuss this. I kind of like, I think it's better than just talking, because I think sometimes when you talk, you absorb such a small amount, but when you go back and read, you can really think about it, So that's kind of why I've kept that model, but I haven't kept it as creating any barrier really, right? But anyway, but in creating all that, I had to sort of create handouts and develop my own treatment tables. I wanted to be able to see the population, access my information very quickly, stay very accurate, and not do anything fly by the seat of my pants, right? So it took me a little while. So in that time, but I did open my doors to saying, hey, I'm LGBT affirmative. So I started taking on some patients prior to being prepared to do any hormone management. So my first patient was already being cared for. The closest gender center that this individual could get hormones with was 2 hours away. Talking about barriers to care, right? And so one day the child came in, or I just adolescent, near adult, came in and said, hey, can you refill this medication for me? And I'm speaking slowly because I'm trying not to violate any HIPAA, right? So my response was, wait a minute, I don't know how to write for this yet. And then as soon as those words came out of my mouth, I realized that I'm being exactly what I feel like this population continues to receive from others. I've had patients actually just within the last month, they came to me that said that they went to a pediatrician, told them their child was trans, and the pediatrician said, well, I don't take care of trans kids, and kicked them out. So this is what this population sees, right? So anyway, so I realized as those words were coming out that I can't do that. So then I said, okay, give me the medicine, I'll write for it. And then I said, I'll tell you what, I'm going to be ready in 6 months, and I'm going to take over your care. This is forcing me to get myself together very quickly. And that's when I really dug in hard with everything, right? And I realized, wow, this population really needs help in this city. Okay, so then my second patient I took on had moved out of the state of Florida and was gone for about, I think it was 6 years, and had to move to a farm of a family member's house way out in a different state, someplace remote, and was homeschooled there because of such intense bullying. This kid, a trans child, tried multiple times to commit suicide, was a mess, so moved to this home, or this family member's home, just for peace, right? And so they came back because, the kid wanted at a certain point to be back with the mother and father. So they came back, heard about me, came to see me. And at the first appointment, I just was like, hey, name, pronouns, simple. And this is what's going on. And I was like, there's, I normalized gender is what I really did, and was kind. So at the end of the visit, the mom and the mom and the adolescent started crying and got me tearful. And I was like, why are you crying? And then they said, well, no one has yet to accept my child's gender. And this is the first time we've had a positive experience in the medical community. And because of that, we stopped going to see physicians. The child had not seen a physician in that amount of time and was incredibly behind on vaccines and on care. That really affected me. And so those two things really drove me to get things going. So from that time, I would say early on when I started practicing, I was starting to receive a lot of patients who like a mixture of patients whose parents were not affirming yet. And boy, so many toxic situations, because I just wanted to kind of like, our home should always be our safe zone, right? Everybody needs a safe zone. Like, it's just, you go out into the world, there's stress, everybody's level of anxiety goes up a little bit. There's a lot of concern, especially for for the LGBT community. And these kids did not have a safe zone. A lot of these kids don't have a safe zone at school, and now they definitely don't, right? And no safe zone at home. And so no surprise that you have an increased incidence of mental health illness, and the worst is suicidality. I mean, there's no surprise when you have no stability, right? This has just been proven in study after study. So yes, it was a problem, but I go back to the incredible collaborations that I've been able to make in Jacksonville with some amazing mental health persons, and we just call each other. I mean, I don't have this relationship with almost any other person. We call each other constantly. We have meetings about patients. It's all, the patients have all, allowed this through HIPAA, and we just work on the back end to help these kids out, to help move the needle for these families, to help them to understand how to manage their kids. I would say that's really transformed, and it might be because this state is now attacking these kids. I'm thinking maybe that's matured or evolved the parents' understanding and thought. It sort of required them to turbo speed their understanding and acceptance of these patients, because I'm getting a lot less of dissenting parents. I'm starting to see parents jump on board and really, really fight for their kids, which has been fantastic to see that. Yeah, I think I've answered your question, right?
There are parents who split up when their children transition and they're at odds. They don't agree with one another, and it becomes a fight, and there's much tension. I know of a number of cases like this, and maybe in later years, the parent who was objecting to the child's transition may come around once those kids grow up, and in fact, I know a couple of them are adults today, and it's no longer an issue. But I want to touch on how you have gracefully prepared yourself and your practice in meeting the needs of this particular population. And you have certainly put in an overwhelming amount of studies to really understand the holistic delivery of care that you provide your patients and their families. It speaks volumes about you, your practice, and again, the empathy you show your patients and families.
Well, Dr. Ahn, the patient experience really starts at the initial phone call. It has to be from the very, very beginning all the way through. The way, even just the practice management system. So just the way, even, for example, our system works, there's a scheduling side of our computer electronic medical record, and there's like a medical record side on the back end. And not necessarily, information doesn't necessarily flow the way that you'd like it to. So really, to do this properly, you have to make sure that there's information put in on both ends so that people are respectful during phone calls, for appointments, during check-in, and then on the back end, on the clinical side, when we're seeing a patient. And, we do have to also understand and accept the fact that these adolescents are continuing to understand and grow, and sometimes their gender and their sexual orientation continue to evolve. And so it's also not only just understanding where they're at, but making sure we update things as their journey progresses. But it's about treating people with dignity and respect, and everybody deserves that. It's also about, there's no reason why we should not normalize these genders, and we respect people and their gender when they're cisgender, and we should respect people in the transgender and gender diverse communities just the same. And so it's just about making sure your system and your whole entire system, the way your office functions, does that. It's as far as I'm concerned, it's really 101. It's practice of medicine 101. It's basic.
We're going to take another commercial break, and we'll be right back.
UK Health Radio, the station that makes you feel good. The station that makes you feel good.
We're back from commercial break, and we're going to pick up with another question. This is my last question, Dr. Sanchez, and it reflects back on all the discussions and research that has been done on bone density tests. There's a lot of debate. In fact, I've had people ask me questions about it. And I do know that I have met youth who've grown up and are now adults who were very active and did not suffer the consequences of bone density loss. I wonder in research if they're studying the activity of children, because what children do today isn't exactly what we did back in our day. We were very active, most of us. Kids now play video games. It's a different type of activity. It's engaging and they use their brain, etc. But they're not physically active, and a number of kids are not even enrolled in sports. So is that taken into consideration in doing these bone density tests with these prepubescent adolescents who are on blockers, and perhaps even their diet? And are they consumers of carbonated drinks? That certainly will have an effect on bone density. What's your opinion about that?
Yeah. So let me explain what the blockers are for a second, right? Because I think it's important to really understand this. So first of all, another way to say it is a puberty blocker. Okay. So number one, it's important to know that I'm going to use the word child to say any, child to say any minor that has not started puberty is a child. Okay. So with transgender medicine in children, it's just about support, love, allowing a social transition, name, pronoun, attire. It's just affirming a child. Okay. Puberty block, any medication, hormone replacement therapy or puberty blockade does not start until puberty starts. You don't block something until it's started, right? Okay. So the idea of a puberty blocker is to decide if somebody is ready for it, that's explored with a mental health person. A mental health person will meet with the child, adolescent at that point, because puberty has started. We'll meet with the family multiple times. We'll come to a point where they feel like psychological, social factors are under fair enough control, and the child is ready for these. And from my perspective, I want to make sure that that's also the case, that there are no medical illnesses that would preclude to it, or any psychiatric illness is managed. Okay, so there's an evaluation. It's not you just throw somebody on it. And then what the puberty blocker does, there's generally it's called Leuprolide. There's one of them, but there's several, and they all function the same way. So what they do is, normally when puberty starts with a signal from your brain. The signal is certain hormones are released. The two are called FSH and LH. They're always kind of released from birth, but they get released in more of a pulsatile fashion, like and that pulsatile fashion of release, and nobody really knows exactly what signal gets that started, but it just starts, and that makes those hormones go to your gonads, okay, whether you have testicles or whether you have ovaries, and they initiate puberty. So that means your testicles will start releasing testosterone and start masculinizing. Your ovaries will start releasing estrogen and start feminizing. And so what the puberty blockers do is it actually stops that process. So it kind of puts it to a point where puberty sort of freezes for a little while. And the beauty of it is that it is fully reversible. When those medicines are stopped, puberty just progresses. But what it does for the individuals is it can prevent them experiencing puberty in an undesired sex. So in particular, for my trans males, the idea of growing breasts, the idea of having menstrual cycles is terrifying. And I've had some that I see that have already started puberty and are already like late end, and just it's a horrendous experience for them. I mean, I think every woman says nobody likes their periods, right? But this is to a whole nother level. And for somebody who is a trans female, sometimes the idea of growing an Adam's apple, which would need surgery to reverse that, growing a lot of hair, a deeper voice, their deeper voice. There's so many unwanted things. So it's a nice way to hold that for maybe an adolescent that's not ready for whatever reason, for gender affirming hormones, that would be the estrogen or testosterone that they would need to affirm them. So maybe they're not ready for that. Maybe they're still a little bit on the young side for that. Maybe they just need more time to grow and understand their identity. Maybe their families aren't ready. There's so many different reasons, right? Okay. So those blockers are great. So now what happens is when puberty starts, those hormones, testosterone and estrogen, also help to develop good bone health. They help bony mineralization. So in stopping or freezing that process for a little while, the concern is that your bones don't mineralize the way they need to. And so you're right with, it's important to make sure you have proper nutrition. I always, with any of my patients on puberty blockers, I have them take extra vitamin D and calcium to help that, because vitamin D and calcium vitamin D helps to promote calcium deposition into your bones. And then physical weight bearing exercise as well. So those are really the mainstay of like, well, what could you do to help? So we also do DEXA scans, which help to look at bone mineralization in the patient population. You ask about fractures. You really kind of like dig into this a little bit, and you can do those DEXA scans regularly. I think what's generally kind of accepted is if you're going to do puberty blockers, kind of 2 years tends to be the time when it's like, hey, by 2 years, a lot of the times these kids are ready for some gender affirming hormones. And then once you start those, it helps to start to mineralize your bones, right? But there are people that can be on the blockers a little bit longer. Not to get into too much detail, but you do, when you are a trans female and you start estrogen, you also need to be on some form of blockade of testosterone. Puberty blockers can be used for that, and other medications can be used as well. So there are some instances where they can be used for longer. Bone health, if you're doing this right, you should follow bone health, which is what I do, and I haven't had really any problems. But the puberty blocker medications are not like brand new for trans medicine. We have used these for a long time for people that have precocious puberty. That means people that go through puberty when they're younger than they're supposed to, and for maybe a pathologic cause. And there's a lot of experience with understanding bony mineralization in those patients. And so even though those patients are not technically trans patients, you can use that information and understand maybe what it does to the body. So far, the studies have shown in general bony mineralization issues. However, so far what it seems like is when individuals have used puberty blockers in the younger, when they're in their 20s, their bone mineralization recovers back to normal. So even that effect is not necessarily felt to be permanent or long-term. There is definitely more studies that need to be done on that. But when you weigh out bone mineralization with identity and all of these other issues that could come, and the fact that puberty blockers have been shown to lower some of the mental health issues that patients have experienced, because while a trans individual can receive stigma from, we've already talked about the society, the way it treats the trans, they can also just have some gender dysphoria based on their own body parts. Like, not all gender dysphoria we can necessarily blame on all these distal processes. There's some gender dysphoria that's just related to body parts. So it can help to lessen that, and that can make a big difference for mental health. So I feel like, in general, if they're watched carefully and all the appropriate labs and evaluations are done, I think puberty blockers, we can say, are a nice, safe, reversible medication that can be used, that can make a big difference in that population. And just on the downside to them, the real issue is they're very expensive. And so because of that, there's a lot of insurance barriers that I've had to jump through so many hoops to get some blockers for some patients. It's just really, it's sad. It's that the insurance companies have created barriers for this population.
Thank you for your time, Dr. Sanchez. This was very informative and hopefully alleviated some of the concerns that some of the individuals in our audience might have had. I'm glad that you covered it in the detail that you did. I hope to have you return again. You have been listening to the Umbrella Hour with Dr. On. I hope you join me next time.